In a narrow aortic route, myectomy is sometimes not feasible. Myotomy with a scimitar blade may be sufficient. Fibromuscular stenosis. Good myocardial protection is paramount in the setting of a very hypertrophied heart. The aortic valve is gently retracted and the area of the membranous septum must be avoided. Venting of the left ventricle provides good visual approach for extended septal myectomy, as the risk of creating an iatrogenic VSD is not insignificant. For a limited wedge excision of the fibromuscular ring, two parallel incisions are made into the ventricular septum. The first incision is made beneath the commissure between the left and the right coronary cusp, immediately to the right of the mitral apparatus, and the second incision is made beneath the belly of the right coronary cusp. Both incisions are deepened and carried inferiorly as far as needed. The two incisions are then connected to a transverse incision beneath the right coronary cusp, and the junk of ventricular septum is excised with scissors. Now we are going to the figure 37.26 to understand this meaning. Yes, we have the left incision and we have the right incision, and in the top we are connecting these incisions and get the muscle from that septum. For hypertrophic cardiomyopathy, the extent of the left ventricle septal myectomy will be guided by the transesophageal findings. The aim is to abolish the dynamic obstruction due to systolic anterior motion of the anterior mitral leaflet and to create a wide open left ventricular outflow tract. The left and right fibrous trigones should be unhinged as described above, and any fibromuscular accessory mitral attachments to the septum should be divided. Any echocardiographic evidence of residual narrow left ventricular outflow tract or systolic anterior motion of the anterior mitral leaflet would warrant further septal resection. Discontinuation of cardiopulmonary bypass requires optimal preload. Atrioventricular synchrony inotropes are not indicated. Tunnel-like stenosis with normal aortic valve. If the severity of the subvalvular obstruction is such that the previously described technique is not sufficient to relieve it, a modification of the Kona operation, leaving the aortic valve annulus intact, partial Kona, may be indicated. Aortotomy incision pointing toward the commissure between the right and the left aortic cusps is carried out. The aortic valve and the subvalvular area are inspected. If the stenosis cannot be resected through the aortic valve, a short transverse incision is made in the right ventricular outflow tract below the pulmonary valve. A right-angled clamp is passed through the aortic valve into the left ventricular outflow tract, pointing toward the interventricular septum, in which an incision is made through the right ventriculotomy incision. The incision should remain above the muscle of Lancisi in order to avoid the conduction system. Superiorly, the incision is carried to within a few millimeters of the aortic valve annulus. Now we are going to see the figure 37.27, what this topic is mean. Now we see in the top, we see that in the left aortotomy, and in the upper part two stitches, and between them the right ventricular outflow tract incision. And when we have done these incisions, for opening the ventricular septal defect, you see in the below the incision that has been shown with clamped. The fibromuscular component of the subvalvular stenosis are excised. A patch of Dacron or Gore-Tex is then inserted to widen the left ventricular outflow tract. And this, as shown in the in our figure of 37.26, in the A you see the left ventricular septal defect, and ventricular septal defect has been repaired with patch, and then the right ventricular outflow tract and aortotomy has closed with continuous stitches. The right ventriculotomy can be closed by direct suture. Small aortic roots and diffuse left ventricular outflow tract obstructions. Hypoplasia of the aortic valve annulus, diffuse obstruction of the left ventricular outflow tract, and the lack of potential for growth after prosthetic valve insertion have led to the design of a number of procedures aiming to enlarge the aortic root. Annular enlargement toward the mitral valve. Two posterior techniques have been described. The first consists of extending the aortotomy incision through the midpoint of the non-coronary sinus across the annulus into the anterior leaflet of the mitral valve. This is the Nick procedure, 1970. The original description involved an incision made in the roof of the left atrium opposite to the aortotomy incision. A composite teardrop-shaped patch of pericardium internally lining a knitted Dacron patch was sutured on the mitral valve and then to the aortotomy incision. We prefer to maintain the integrity of the mitral valve leaflet. One should also keep in mind the possibility of an abnormal circumflex coronary artery arising from the right coronary artery and coursing posteriorly, or a sinus node artery arising from the circumflex coronary artery. Therefore, the incision into the aortomitral curtain is stopped well short of the mitral fibrous annulus. Now we see the Nick procedure, and first the incision line which shows us in the non-coronary cusp, in the middle of the non-coronary cusp, and it is extended not to the anterior mitral leaflet but fibrous trigon of the anterior mitral leaflet, and then the patch is sewn, therefore the incision into the aortomitral curtain is stopped well short of the mitral fibrous annulus, and the patch of bovine pericardium is used. The enlarged aortic annulus is calibrated and the valve substitute is selected. Pleated horizontal matrix sutures are first passed through the patch and finally through the sewing ring of the valve. The rest of the prosthetic valve is then sewn in the usual fashion to the aortic ring of the left and right coronary sinuses. Now we are going to see how the aortic valve implanted. You see the figure 37.30, and then how the aortotomy is sewn with the patch of the continuous in Nick procedure. The proximal aorta is concomitantly enlarged using the teardrop-shaped patch. Another technique of posterior annular enlargement was described by Manoogian and Seibold-Epting in 1979. The aortotomy incision is directed toward the tip of the commissure between the left and non-coronary sinuses. This has imagined in figures 37.31, and we are going to this picture. Now you see that the incision line is between the left coronary cusp and non-coronary cusp. The line is here, and the incision has extended to the fibrous annulus of the anterior mitral leaflet. Now we are going to the text and reading this Manoogian technique. The left atrium is dissected away and the incision is carried through the area of fibrous continuity between the aortic and the mitral valves. It is often possible to stop the incision immediately above the hinge of the anterior leaflet of the mitral valve without opening the left atrium. A teardrop-shaped bovine pericardium patch is then inserted with a continuous 4-0 Prolene suture. Once the enlarged aortic root is prepared, the insertion of an aortic valve substitute should follow the technique described earlier. Some surgeons prefer to use the mitral valve of the aortic homograph into the patient's anterior leaflet of the mitral valve. Thank you very much.